Starting the second half of Chapter 2, we're dealing with pharmacodynamics, and the figure I've put up here sort of shows some of the terms that are used in pharmacodynamic discussion. That is to say, agonist and antagonist, inhibitor or modulator. Adrenergic and cholinergic are actually a little more specific. They're a little more specific in terms of what types of receptors they're interacting with. Nevertheless, we would use this term in combination with something like agonist or antagonist, inhibitor, modulator. So let's get started. We have a few more receptors to cover, and then we'll move into some other general concepts of pharmacodynamics. If you recall from last time, we discussed receptor channels, also known as ionotropic receptors. We also discussed, and you saw some examples of G protein coupled receptors, a very, very common druggable target, and the G protein down here, which is that second message. One that we're not going to talk about, and I blacked it out in the previous one, but I'm going to go ahead and put an X through it right now, are the integrin receptors. I don't think we're going to talk about any drugs that affect integrin receptors. Integrin receptors are basically receptors that tell a cell that it's in its right place. It'll help a skin cell stop growing, fibroblasts from stop growing when wound healing and things like that. Not a ton of drugs that are in traditional clinical practice affect integrin receptors that I know of. But if I spot one, I'll point it out. But what we're going to focus on right now over the next few slides are known as the receptor enzymes. That is to say, when a molecule binds the receptor on the outer surface of the membrane, it triggers the change in the shape of the protein, which then allows it to catalyze a reaction. So let's take a look at some of the receptor enzymes. So as I mentioned in the previous slide, receptor enzymes, when they're activated by some chemical, like for instance an endogenous molecule, or perhaps a drug that mimics the endogenous molecule, what we get is a change in the shape of the protein, and that change in shape allows it to catalyze a certain type of chemical reaction. This is a receptor enzyme that takes GTP and turns it into a circular molecule called cyclic GMP. That's what that lowercase c means. We're not going to talk a ton about these. Really where I want to go is what are called kinases. So kinases, what they do is when they're activated, they will phosphorylate proteins. So here's a classic receptor enzyme. We call this a tyrosine kinase receptor, and I'll explain what that means here in a little bit. And I hope that you're able to see this animation. I have not tried this before, so let's hope for the best. In any case, I'll explain what's going on here as soon as the animation recycles for me here. So what we have are actually two separate receptors, and when they bind the what's known as a ligand, it could be a growth factor or it could be a drug, that causes the two subunits to come together. We call that dimerization. Now, as I mentioned, this is a tyrosine kinase, which means that whatever the target is for the kinase, that's what these red squares are at the bottom, that's the kinase domain. When those are turned on, they will phosphorylate a specific amino acid on their target. And that specific type of amino acid is a tyrosine. So it's a tyrosine kinase. Our tyrosine kinases have dimerized. They've formed a pair. And it turns out what they do is they actually phosphorylate tyrosines on each other. So one tyrosine kinase domain phosphorylates tyrosines on the other receptor and vice versa. This is known as autophosphorylation. But what it's doing is it's changing the shape of this receptor dimer, kind of like laying out the red carpet. By phosphorylating those kinases or those tyrosines, you are opening up those tails and creating spaces for other proteins to come in and dock. So once those receptors have autophosphorylated, like I said, it opens up those tails, like laying out the red carpet to say, hey, welcome, come in and bind with me. The relay proteins, in this case, are showing GRAB2 and SOS. These relay proteins come in and bind and may be phosphorylated by the receptor, or they're otherwise changed and then can cause signals to be relayed out into the cell, in the cytoplasm, or going all the way down to the nucleus. And so that's an example of a receptor enzyme, in this case, a tyrosine kinase. Common enzyme families include those receptor enzyme that I showed you earlier that makes a cyclic second messenger. I just showed you the kinases, and I have a little animation for you. What a kinase will do is it will interact with a target. Usually it's a target protein. It'll use ATP, transfer that gamma phosphate off the ATP, so we're left with ADP. And now we have a phosphorylated target, which has a changed shape. I'm not showing it very well here, but that target will almost always have changed its three-dimensional structure ever so slightly, or in some cases significantly, altering its behavior in the cell. We also have the opposite. Now, kinases will not generally dephosphorylate a target. They will only phosphorylate. They can only catalyze this direction. What we have that will reverse this type of a signal or this type of a change is what we have, what is called a phosphatase. Phosphatase, not phosphorylase or phosphorylase. You'll see those words. It's phosphatase. So a phosphatase only catalyzes the removal of that phosphate. It doesn't transfer it back to ATP. It just pops it off. And so now we have a target that's no longer phosphorylated, and we have what's called inorganic phosphate out here. But this is sort of like a molecular on-off switch or a molecular modulator that when we phosphorylate a target, it will change its behavior, and we can reverse that by dephosphorylating it. But some other targets out there, common enzyme families, not only include what we talked about, ionotropic receptors, but we also have carriers out there, and there are other enzyme families out there that drugs can and do target. Other sites of biologic targets that are not involved with a cell in our bodies would be pathogenic cells that enter our bodies. That could be parasites, or in this case, bacteria. And we see all kinds of drugs out there that will target bacterial function. We call them antibiotics. For instance, what we call the beta-lactam inhibitors, they inhibit the formation of a cell wall around a bacteria, which it needs to survive. And so you can see penicillin in there and some other forms that inhibit cell wall production and thus facilitate bacterial cell death. All kinds of, if you're talking about inhibiting protein synthesis, inhibiting or interfering with the cell membrane, metabolic pathways, but the fun one down here, fluoroquinolones. These are, for instance, like hydroxychloroquine would be in that family. Inhibit nucleic acid synthesis. So if it inhibits some sort of bacterial cell function, it is a potential antibiotic. The same is true when it comes to subcellular pathogenic molecules, like for instance viruses. And again, we can inhibit the binding of the virus to the cell. It has to be able to bind or it cannot invade the cell. And that's why certain viruses have proclivities for certain cell types. Viruses that bind and enter liver cells, hepatitis. Cells that bind and enter immune cells, HIV. Cells that bind and interfere with lung function, that's our COVID-19 right now. In fact, it turns out is a really, really interesting protein called ACE that we're going to talk about for blood pressure that we find in lungs. That seems to be one of the keys for viral binding in the lungs. But any function that the virus requires in order to take over that host, which includes releasing the genome, turning it into viral proteins and packaging, are what we collectively know as antivirals. So again, those fluoroquinolones may be involved in that taking that mRNA from the COVID-19 and turning it into proteins. So there's a really interesting thing going on here with that, I think. But again, possible targets are listed here. We even have non-cellular targets for certain specialized kinds of drugs. For example, ion chelators. If somebody swallows a heavy metal of some kind, like for instance, if they swallow pennies or coins, or if they accidentally ingest mercury or arsenic, you can use lead. Lead is another big one. Bivalent metals as a whole. You would maybe administer a chelator to try to bind that metal ion in order to prevent it from being as reactive in the body. The hope is that by binding up that metal ion, it's no longer reactive, no longer going to do damage, and can be safely excreted from the body. But it's not binding a cellular target at all. It's binding actually the metal ion. One other example that the book discusses a little bit is the idea of, again, a non-cellular target would be like a chelator. What you would do is you would bind the potentially, the substance of interest in the digestive tract, thus preventing it from either being degraded, preventing it from dissolving, preventing it from being absorbed, and thus facilitating excretion. What happens is if we don't absorb something in the GI tract, it passes on to the fecal route and is removed from the body. So like a chelator, we can also affect, and this sort of ties in a little bit to pharmacokinetics, but it is still technically pharmacodynamics because you're affecting the biologic activity of the molecule in question by preventing it from being entered into the bloodstream. So our next topic of discussion involves the drug-receptor interactions. That is to say, when a drug binds a receptor, so when we have the drug-receptor complex, that leads to effect. So let's talk about this a little bit. So the sort of basic model of what we call specificity and selectivity involves this sort of lock and key analogy that the receptor is a lock of some kind. It has a special three-dimensional structure that only certain molecules with a given shape, like in this case A, but not B, can bind here. So A is a specific drug that binds to the receptor, leading to action. But B is not specific and it doesn't have a close enough approximate shape to bind to that receptor. So we're talking about specificity. So this receptor is somewhat specific or highly specific for A. It may, if there are other molecules out there that look like A, maybe they can come in here and mimic the action of A. And this is a very, very huge topic. So if you were to go over and to see some of the drug development studies that go on at places like Eli Lilly or Novartis or Merck and so forth, they spend a lot of time trying to predict the three-dimensional structure of the receptors that they're interested in inside cells and develop a drug, modify it here or there in order to make a better fit and a stronger fit. Like for instance, this drug over here may be able to fit in here and create an effect of some kind, but this new drug, when you change a thing like here and here or maybe over here, has many, many more sites of interaction, which means that this drug probably will bind much more strongly and have a greater effect. So it has enhanced specificity and enhanced affinity. This is a better drug than this one because it fits better and it will be more likely to stay bound rather than pop off. And those interactions between the drug or the molecule and the receptors give a drug its selectivity. If a drug has low selectivity, it means that it will act in multiple receptor sites. If a drug has high selectivity, it means that it will act at relatively few receptor sites. For instance, we have what are known as the adrenergic receptors. And adrenergic receptors are sensitive to things like epinephrine and norepinephrine, but there is some selectivity. So for instance, maybe norepinephrine can bind a certain subfamily of alphas and beta adrenergics, and epinephrine can bind with different affinities and different selectivities of those receptor subtypes as well. But it comes back to that sort of lock and key mechanism that I showed you in the last couple slides. So here's what I mean by differential selectivity in those adrenergic receptors. If you look at epinephrine, it can interact with the alpha 1 and alpha 2. It can react with everything in this set, but it doesn't react with another type of receptor called a dopaminergic. Ephedrine, which is a close cousin of amphetamine, by the way, again, a non-selective interactor with adrenergic neurons. Norepinephrine has a slightly more limited set. It'll act with alpha 1 and alpha 2 and beta 1, but not beta 2. Phenylephrine, alpha 1 only. Isoproterenol, that's a beta blocker, only interacts with the beta receptors. Dopamine, on the other hand, can not only interact with the dopamine receptors, it can affect beta receptors and even an alpha, so it's relatively non-selective, even though we've even named a receptor after the dopamine. And so forth. So you can see varying degrees of selectivity. Dobutamine, terbutamine are relatively selective for beta 1s and beta 2s respectively. Two of the most important phenomena that involve drug receptor interactions are the concepts of potency and efficacy. So in this picture right here, what we have is we have on the x-axis we have the dose, and it's in a logarithmic. That's not important for us. What it's saying, though, is that to the right you have a higher concentration in the blood in this case. And then we have some sort of a biologic response that we're measuring. Like, for instance, let's say heart rate or pupil dilation or something along those lines. It's a quantified response. What we see here is that drug A has a higher potency than drug B. We begin to see effects at a lower dose. But drug B has eventually a higher efficacy. That is to say, it will achieve a greater response than A possibly could, because what we would project is that this would flatten out and you'd maximize. So if we hit a maximum here at B that's higher than A, that means that B has higher efficacy or is more efficacious, but A has more potency. You can achieve a certain amount of effect with less dose. Another concept that we will bump up into that sort of relates to receptor-drug interactions in pharmacodynamics is this idea of 50%. In this case, we're talking about the EC50. That's the concentration that achieves a 50% of the maximal measured effect. And it can be, things like pupil dilation or something along those lines. So we're measuring some kind of an effect, and the concentration of drug to achieve that 50% of maximal possible effect. So maximal, this Emax is maximal possible effect. The concentration therein would be the EC50. And in this case, if we put our 100, looks like just about right here, it looks like our EC50 is going to be somewhere in the 130 range if you look at it right here. So 130 units, whatever the units are of this drug, and this is drug plasma concentration usually, achieves a 50% of maximal effect. So its EC50 would be 130. Now if we look at another drug, drug B right here, we can see that they have equal efficacy. So their maximal efficacy is somewhere around the 87 or 88% of the maximal possible effect. So they're equally efficacious. They have equal efficacy. But however, B has significantly less potency because its EC50 is somewhere in the 350 unit range. So it takes 350 units of B in order to achieve 50% response, where it only requires 130 of A for that 50% response. We often measure things in 50s. That's because if we get out here, we're always in usually, and I'll explain this in a little bit, we're usually in some range where we don't want to be. Yeah, the effect is great, but when we get into these higher concentrations, the opportunity for side effects and adverse responses goes way up as well. And here we have a similar plot as the previous slide, only this time instead of a linear x-axis, we have what's called a logarithmic x-axis. A lot of things in nature behave logarithmically. If you think about pH, if you think about decibels in terms of sound, and drug concentrations are no different. In fact, it's quite using a logarithmic scale is actually more useful than a linear scale most of the time because it allows you to see orders of magnitude that you couldn't normally plot in a linear scale very easily. And so again, here's EC50 for this first one here, a little north of 100 units for this one. Again, Emax is up here. This drug actually achieves Emax, unlike the A in the other plot. And here we have a second one showing you, again, equal efficacy. Okay, they can both achieve Emax, albeit at exceptionally high drug concentrations, but because the blue line has a lower EC50 than the red line by a significant amount, I would say, it's much more potent and equally efficacious. Just a little thought exercise here. I know this videos are not as interactive as I would like them to be, but in this case, before I give you the answer, I would like you to rate the potency of each drug and how would you achieve that. So I'm going to give you 10 seconds to do that, starting now. Okay, so how would you calculate potency? Well, the easiest way to do that is to find the EC50 of the drugs. Okay, so find the EC50, just find the 50% mark over here. Okay, 50% mark, if this is Emax, that's 100. So here's 50%, draw a horizontal line across your graph, or you can visually imagine it. And then draw or imagine a vertical line down from wherever these curves intersect that EC50 line. So the EC50 for A would be somewhere around 100 milligrams per kilogram. The EC50 for B would be somewhere around 1,000 milligrams per kilogram, a gram per kilogram. That's a hefty, hefty dose. And then C, the EC50 would be somewhere around 5 or 6 grams per kilogram, which is a whopping dose. I mean, I don't know, you might be talking about like an egg, amount of material. That's huge, okay? So in terms of potency, A is about 10 times more potent than B is, if you think of 1,000, 100 and 1,000. And again, we're much more potent than C. I should have a double greater than right here. Now let's try efficacy. So how do we measure efficacy? I'm going to give you 10 seconds, and I would like you to just, for your own purposes, just try to rank it on your piece of paper real quick, starting now. Okay, to measure efficacy, we look at the peaks of the curves. Okay, now first of all, this one is shooting up above that arrow. That doesn't happen. Really, you really can't ever, with any drug, you can never achieve the maximum that is theoretically or naturally possible. Like for instance, there's no such thing as a drug that you can take and all of a sudden you have some superpower like being able to breathe fire or something. In any case, so we are going to assume that we hit Emax right about, right in here. That's close enough for our purposes. Okay, so we hit 100. We hit 100% with A. We also hit 100% with B. Okay. Now C doesn't seem like even with 10 grams per kilogram, that's crazy, we never get above, say, 65 or 70% of Emax. Never get there. So in terms of efficacy, A and B would be the same, and they're both greater than C. C is a pretty lousy drug if you ask me, okay? EC50 is way high, okay? And efficacy never gets there. It's not a very good drug, okay? But that's how we can compare potency and efficacy. And the quicker you can do this, the quicker you can look at the graph and just analyze it real quick, the more sharp you will be if you find yourself in one of those sort of technical discussions if you're looking over literature of a drug or something. If we take the concept of efficacy and begin to subdivide it a little bit, we come up with these three terms. We have agonist, partial agonist, and antagonist. The idea being is that if something is relatively efficacious, that is to say, let's say above 50 or 60%, we can classify that as an agonist. And again, there's no hard set number here, just something anywhere above 50 or so we could reasonably classify as an agonist. Ideally, a true agonist would get us to 100%. Okay, an example of an agonist that is both endogenous and exogenous would be something like insulin. So insulin will bind the insulin receptor and achieve an effect, or we can administer insulin as a drug and it will interact with the insulin receptor. Or we think about epinephrine as an agonist for all the different adrenergic receptors, while norepinephrine was only an agonist for some of them. On to partial agonist, and the best definition here is that it can achieve some biologic effect, maybe let's say 50% or less. And then antagonists generally do not have any biologic effect no matter how much you give them. But here's the thing. If we start administering any of these guys together, that is to say, if we administer an agonist and a partial agonist, oftentimes they will compete. And that partial agonist also will inhibit the ability of the agonist to achieve full effect. That gets to competitive inhibition if you remember your cell biology. A full-on antagonist will do the same thing. It could impede or completely block a partial agonist, or impede or block a full-on agonist. Again, a partial can inhibit an agonist, and an antagonist can inhibit a partial agonist or a full-on agonist. We have a little more to break this out. I don't want to confuse you too much. Start with the efficacy first, and then think about the idea of inhibition. The next question, if we're talking about something that is an antagonist, is whether or not that antagonist is competitive or non-competitive. If the antagonist is competitive, that means that the molecule that is the antagonist is competing for the same binding site on the receptor. And what we can see is that we get a right-hand shift. So let me draw that in here real quick. We get a right-hand shift in the response curve because what we're talking about down here at the bottom is the drug concentration. We're only talking about one drug. So all these different curves are the same drug. Okay? So we have a right-hand shift. That's because it takes more drug to achieve the same effect when we have a competitive antagonist. So you add more and more agonists, you end up getting more and more possibilities that the agonist is actually binding the receptor rather than the competitive antagonist. It's competing for the same site, so more will overcome the inhibition. Okay? We achieve the same level of inhibition. On the other hand, if we have what's called a non-competitive antagonist, that non-competitive antagonist is binding a different site on that receptor. And so what a non-competitive antagonist will do is prevent it from ever achieving its full effect, because that non-competitive antagonist is affecting the shape of the receptor in such a way that the drug can no longer bind it with the same level of efficiency as it could before. It's changing the shape. That non-competitive antagonist is changing the shape of that molecule, and so it doesn't bind the agonist as efficiently. So we can still achieve a maximum effect with our agonist, and this one just happens to be near 100%. Maybe it could be a lesser one. It could be 75 or something. But nevertheless, we can still achieve it with the competitive. With the non-competitive, however, we can never achieve that maximal effect. That's because they're not competing for the same site. That non-competitive antagonist is changing the shape and thus changing the ability to create a response. Another way of describing competitive inhibition versus non-competitive inhibition, again, we can do it biochemically by saying where it binds on the receptor, okay? Usually the same spot, different spots, and that's why the receptor is changed. But you can also paraphrase it this way. That is to say, competitive inhibition affects potency. If we inhibit, we need more drug, which means that the EC50 is now a higher number than it was before. So we add a little bit of antagonist, and now the EC50 is no longer somewhere around 1, it's now somewhere around 5. Okay? If we add a little more of that antagonist, it was going to take something north of 10, like maybe 10, 10 or 15. So we were seeing a right-hand shift in the curve, and that right hand, remember that we talked about the horizontal shift as a function of potency. Okay, so competitive inhibition affects potency, but non-competitive inhibition affects efficacy, because now, again, here's the maximum efficacy for norepinephrine in this one, but if we add this inhibitor, what do we see? We see a drop in the, sorry about the terrible arrow there, we see a drop in the overall maximum effect. And if we add twice as much, we see an even more significant drop. That's efficacy for the non-competitive inhibition. And again, why is that? Because we're binding a different site on the protein or the receptor. Usually it's a protein. On the receptor, it's changing its ability to either respond or changing its ability to bind the agonist at all. What we can also see, and this is sort of the interface between pharmacodynamics, that is to say, agonist and receptor interaction, whether we're talking about drug or some endogenous molecule, with what we call pharmacogenomics. There are different isoforms of receptor that are enriched in different types of genetic populations. And some people may have a hypersensitive receptor, and some people may have a very low activity receptor. If you map this out, if you map out the number of people who achieve a drug response, whether it's low or it's high, we call this sort of curve that we generate in a varied population, how a drug affects the response. We call this a quantile dose response curve. Because I am not an expert in pharmacogenomics, other than that I understand the genetic aspect and the variance at the biochemical level, this is a more of a statistical method for predicting responses in a given varied population. How many people are going to be high responders, which may be a problem. You may not want that much response. How many people are going to be refractory to the standard dose and may either need more dose, which could have toxic side effects, or we might have to come up with a different drug. But that's what this curve is called. It's called a quantile dose response curve, and it matches population versus the intensity of a response based on dose. Our last couple of slides today are going to deal with a concept that I feel is exceptionally important for good, honest, responsible drug therapy and responsible discourse about the benefits or risks of a given type of drug therapy. I believe that this concept will serve you well beyond your professional career, and it is of exceptional importance right now as we deal with this COVID-19. And I'll come to my point here in a few minutes. What we have here, though, is actually two different graphs. We have the dose response curve over here on the left. That's showing you the efficacy and it's showing you the potency, okay? Maximal efficacy for this drug is quite high, okay? Close to 100. Here's an ED 99 this time as opposed to, say, an ED 50, okay? In any case, it's showing you that this drug has potency and efficacy, and that's fine. But over here on the right is the toxicity response curve. So it is showing you, instead of looking at a beneficial response, now it is measuring some sort of toxic response. Okay? In this case, what we have is a dose here is going to achieve some kind of toxic response. It's not quantitating the amount of toxic response. This could be LD50. This could be lethal dose. This dose right here, somewhere around 250 or so, kills 50% of the patients. Okay? It is measuring the percentage of patients who will experience some kind of adverse response. Okay? Some sort of untoward response. Here we have a dose that 1% of the patients, and this kind of feeds back into that quantile, if you will. But in any case, it's the same story as we talked about with dose response curves. We have a curve for effect, the beneficial effect, the therapeutic effect, and we have a curve for the toxic effect. And that in between, say between here and here, and I'm just going to draw this roughly because it's more a conceptual thing, is known as the therapeutic index. And it's basically the concentration distance between a standard effective amount that you want, let's say 50% of patients, and a toxic effect that you want to avoid. In this case, this drug has actually got a relatively wide therapeutic index. Why? Because we can get 99% effects in our patients. So 99 out of 100 patients are going to have some kind of an effect that we want, and 0 are going to have any untoward effects. If we try to squeeze out that 100th, we might just find ourselves in the realm of somebody with toxicity. But if we go any further than that, then our rate of toxicity goes up significantly. Let me show you in the next few graphs. I'm going to give you some examples of this. The idea of a wide therapeutic index versus a narrow one. So here we have, again, a relatively okay. It's not as good as the last time. What we can see is that our effective dose, or our EC50, is basically the same thing. We can achieve a therapeutic effect in 50% of our population, with 0 getting a toxicity. If we try to squeeze out a higher dose, we can see that pretty soon we start to see toxicity in some of those patients. So this isn't too bad of a therapeutic index. At least we can get most of the patients. We're going to watch for toxicity, but nevertheless, we can be reasonably sure that whatever we're giving the patients, that that toxicity will be somewhat unusual. Okay. Now let's compare this to a drug with a narrow therapeutic index. Look what we have going on here. So here's our EC50. I can draw that in here real quick. So there it is. You can see that even at EC50, we're seeing toxicity in some of the patients. We're seeing toxicity in maybe 5 or so % of our patients, and that's a drug that is a very we have to be very careful about. Because if we increase dose, we're going to see a significant increase in toxicity. Yes, some patients will need this drug in order to survive. Chemotherapeutic agents are notoriously narrow in therapeutic index. Okay? There's a relatively morbid joke. You can achieve 100% cure rate with any type of chemotherapeutic drug. The problem is you'll probably kill up 100% of the patients when you do it. Again, that's morbid. We would never think that way, but it's true. When you look at the EC100, we're going to, let's say this is lethal. We're going to kill, if we just hit EC100, we're going to kill 50 or 60% of those patients. And this is a narrow therapeutic index. So your goal here is to understand what it means to have a wide and a narrow therapeutic index. Very important, and I'll show you why here in the next slide. And here's an example of where having an understanding of therapeutic index will give you a really important insight into drugs that come up in the national discourse. And the example that I have for you is this one right here, otherwise known as hydroxychloroquine. Or if you just happen to lop off that OH up there, you would have straight up chloroquine, which is actually more toxic. These drugs have been known for about 50 years. They've been used as anti-malarials. They're also used for rheumatoid arthritis. They're considered what we call DMARDs. They're disease-modifying anti-rheumatoid drugs, which we'll talk about when we get to arthritis. In any case, there was a report that was issued that said there may be some clinical benefit to giving hydroxychloroquine or chloroquine to patients, and that there was an improvement in clinical outcomes. The problem being, and this was spotted right away, never mind the small number of people in the trial, the problem that people knew instantly was that these two drugs and other anti-malarials that are similar to them, antibiotics, have a narrow therapeutic index. Okay, that is to say, toxicity pops up very, very quickly and will be seen in a significant number of patients. It doesn't mean that it's a common thing. Nevertheless, it does happen, and it happens with enough frequency that we would have to be very, very careful unless there was a huge benefit. There would have to be a substantial benefit for these drugs to merit the type of risks that we would ask patients to assume if they took this drug. So some of the major risks include eye retinopathy and cardiac events. That's probably the more significant one. You know why? Because many of the people that are presenting with significant COVID-19 disease have comorbidities. They have diabetes. They have heart disease. They are obese. They have asthma or COPD. And so if we're going to give them a drug that stresses their heart even more, it might just push them right over the edge. And that's why we have to be exceptionally careful, especially when these drugs get out into the public sphere of debate, because you will get lots of people, and they're plenty smart, but they're not experienced in understanding this idea of therapeutic index. Okay, they don't understand that it's not just about quaffing some antidote and you miraculously recover. We're talking about very, very specific biologic effects and very, very specific adverse effects, and we have to balance the benefit of those two. This is the article right here that just came out within the last 24, 48 hours. The idea of the risk of cardiac arrest and how doctors can minimize the danger. They have to understand therapeutic index. They have to be able to dose at a level that has an effect. Sure, you could dose very, very low. Does it have an effect? Is it prophylactic? Does it protect the patients? Or is it protective for somebody who already has the infection or not? And then if you try to increase the dose, at what point is the risk of adverse effects outweighing the benefits that could be incurred by such a drug? So that's it for today. Thank you for your time, and I will see you in Chapter 3. Thanks.